currently. I've been a nurse almost 7 years now in the CVICU. Started at BUMC, Baylor University Medical Center, went to Baylor All Saints for 4 years, and then now I'm at UT Southwestern. Just to get a glimpse, who all has gone through like critical care in nursing school? Okay, cool. Who all is currently in the nursing program? Okay, perfect. So I'll go very basic. This topic is the world of ECMO. Has anyone heard of ECMO before? Yeah, it's definitely gotten a lot more popular since post-COVID times. We used it a lot during that time. But I'll just go through the very, very basics of what ECMO entails, and it's sort of the most acute process that you'll end up experiencing if you go into CVICU post-graduation. But it's very fascinating. It's a field that's growing very rapidly now. So it's definitely something that will be even more practiced once you all get into practice and all that stuff. But yeah, other than that, so we'll go into what is ECMO exactly. ECMO stands for extracorporeal membrane oxygenation. It's basically the advanced life support option, most advanced that you'll reach. The two things here are different circuits that you can use. And the two main types is called veno-arterial ECMO and veno-venous ECMO, or VA-VV. Veno-arterial, basically, if you know the path of circulation through the body, you're going to be taking the blood out of the venous system, which is what delivers it back into the heart, and then you're going to oxygenate it and everything, and then put it back into the arterial system, thus bypassing the heart and the lungs. If you're in veno-venous ECMO, you're going to pull that blood out of the venous system and then oxygenate it and return it back into the venous system. So your heart is going to be pumping that blood, oxygenated blood throughout the body, but your heart is essentially still working. So these are the main two types that you'll see most of the times. And then from an ECMO standpoint, when you're in practice, we structure most ECMO programs from having a bedside ECMO nurse and an ECMO specialist, who is someone who's had many years of ECMO experience. They've gone through training, what we call wet labs, where we actually practice with air getting into the circuit, removing that, troubleshooting in emergencies, and then assisting with cannulations when they put them on ECMO, which we'll go through a little bit later. But they sort of act as a team. It's a 2-to-1 ratio, essentially, and they are okay until it's not. They could get really, really sick really fast, and it's all about just optimizing them through a multidisciplinary approach. So what are the ECMO components? You'll have basically three things. It sounds very complicated, but essentially it's really not. You'll have a pump, an oxygenator, and a console, essentially. And then you'll have a bunch of like PVC tubing that connects all of these components together. But your console is going to be the one that controls all your settings. You'll see pressures, you'll see how much you're flowing on ECMO. Your pump is a centrifugal pump, so it's essentially pulling the blood out of the patient with negative pressure, and then pushing it past the pump with positive pressure through the oxygenator, which is one like this here. That will oxygenate. That's essentially your artificial lung, essentially, and that's going to oxygenate, remove carbon dioxide. Y'all will learn more about that in critical care for those that haven't. But it's essentially how we manage like super horrible arterial blood gases. So it goes through the oxygenator, and then it will return back into the patient as oxygenated blood. So sort of what we were going back, the VV and VA aspects, that's sort of how you can mimic bypassing the heart and lungs, or just the lungs in general. The ECMO specialists deal with a lot of this, but the bedside nurse, which is what you'll get trained first if you're in CVICU, will be still understanding these concepts, but you're more so treating the patient, and the ECMO specialist is managing the pump and dealing with all that. So going forward, what type of indications would be needed for this type of thing? So for VA ECMO, essentially it's going to be anything that causes your heart not to pump blood forward. So you'll have cardiac arrest, cardiogenic shock, pulmonary embolism, post-cardiotomy shock when they have cardiac surgery and they can't get off the bypass machine, and an acute MI. All of those sort of go hand in hand, just different ways to cause the heart not to pump. And then essentially with ECMO, it's not a cure for anything. It's it gives you time to figure out what is wrong with the patient. So what we call it is like a bridge to something. So if they're gonna go on VA ECMO, a lot of times they're thinking, are they gonna be able to bridge to like a ventricular assist device? Are they gonna be bridged to a heart transplant, or just being able to recover in general and give them time? And it happens like that. I've seen it multiple times. But it definitely gives them time when you wouldn't have any other situation without this type of treatment. And we'll go through a case in a little bit of a really cool situation on how ECMO may let them survive. For VV ECMO, as you can see, this is an x-ray a lot of times with these patients. They're in what we call ARDS, or acute respiratory distress syndrome. That's basically where the lungs are so stiff and either like overloaded or something's super sick with them, where they're not able to do any oxygenation or ventilation. These people are like maxed out on your ventilator settings, the highest you can go. They're on countless sedation, paralytics, and you're maybe proning. This is what we had a lot with COVID, whenever that was happening a lot. So you're trying every single type of treatment, and they're still like, their oxygen saturations are in the 80s, 70% sometimes. And they're just the sickest you can imagine. But once they get on ECMO with these type of patients, then they end up being able to do oxygenate and ventilate with CO2 removal. So ARDS is the ultimate reason why they end up getting on VV ECMO. But what can cause them to go into ARDS is flu, COVID, and then trolley, which is getting overloaded with too much fluids and products and stuff. And then same as the VA ECMO, we're bridging to either lung transplant or just recovery. And those are sort of the options if we're gonna go that pathway. And then now we'll sort of transition into more of what this topic is about, is going through how ECMO is used with cardiac arrest. So going forward, has anyone done their ACLS already?
Yep.
None? So I'll go through sort of the basics of what ACLS is. And they sort of go through this in your S1 critical care class. But essentially it's the American Heart Association's algorithm for advanced cardiac life support. So if they go down, you're looking at their rhythm. Is it like VFib or pulsal speed tach, or you can shock it. You're doing compressions. They may give epi or amiodarone for drugs, and they're doing respirations for maintaining an airway. So essentially that's what all hospitals have been trained on to do traditional ACLS. And I think that gives them maybe a 3 to 4% chance at recovery if they end up coding. Very, very low percentages. But now that ECMO is evolving into the concept, we're turning into a thing called ECPR. So cannulating and putting them on ECMO while they are coding and arresting, essentially. And that is actually getting us more up to 30 to even here in a minute with, it was sort of like an ECPR case. But that's where the future is heading, essentially, with cardiac arrest management, is using ECMO to do that. And through the conferences like ELSO and all that, they're starting to normalize that more, and it's becoming more readily accepted upon a bunch of different centers. So that's why I decided to do a topic on this. So ECPR, it's very complex. One of the most acute things you'll ever do in nursing, probably, and one of the most intimidating things you'll do in nursing as well, probably. We started an ECPR program in 2022 at All Saints, but essentially it's a multidisciplinary approach with the emergency department, the CVICU team, the outside hospital like EMS, understanding ECPR candidates and bringing them to the center. But essentially it's all this training, getting everybody on the same field. So this is sort of the setup here, is like an emergency room setup for an ECPR. They're gonna be coding probably on the bed there. You'll have an ECMO pump there. You'll have the cannulation trolley for like the equipment for the cannulation, which we'll go through an actual video of what we had created to show that process. And then an ultrasound, they use that for getting into the vessels accordingly, plus all your other like crash cart and all that stuff. Here's a picture of like an actual ECPR going on. As you can see, it can get very intimidating real fast, and it definitely is education to make that flow more smoothly. And then the New York Times actually published an article recently on ECPR. So that's sort of where I was going back to. It's becoming more readily accepted upon centers everywhere. We had been, so at Bumsey, we were doing ECPRs way back in like the 20-teens. But now it's after COVID especially, that's sort of like the hot trend that everybody's going towards now. So it's never hurts to learn about it sooner than later. Yeah, so that's pretty much really the sort of the look of an ECPR case. ECPR in the field. So we don't do this in the United States currently, but in Europe they don't have an FDA, so they're able to implement unique, innovative processes quicker. So this is in France. This was a patient that went down in cardiac arrest in the subway, and they ended up responding, and then they steriled up and is actually cannulating and putting them on ECMO in the subway, which essentially is the ideal situation for an ECPR. Sort of like with a stroke, time is of the essence. So the longer you wait, the more time that it allows for that muscle to die, the cardiac muscle. So that's what they've sort of implemented there. They've also done it in the Louvre or whatever it's called. In France, they've cannulated in there with a patient that went down. So that's sort of what maybe in the future will come in the United States. We're just a lot slower when it comes to that stuff. But this would allow you to essentially bring a helicopter with the equipment to bypass all the traffic. You could get them cannulated on flowing, so it's bypassing the heart and lungs, allowing them to stabilize, and then transport them to a center for recovery after that. And I'm sure that will actually bring up the percentage of recovery quite a bit. The closest thing we're doing to this right now in the United States is Minnesota. Got this huge ambulance looking truck, and they can actually cannulate a patient in the truck. And that's been sort of the thing the past couple of years that they've been working towards. So we'll see what the future entails, but I like to show this because other countries are able to do things a little differently. So it's very a wild concept. So this is sort of the case that I was talking about. This was actually at All Saints, and the ECMO coordinator actually, we published this in like the ASAL journal and presented at ELSO. But this was a really unique case and showing what a refractory cardiac arrest patient would have died essentially if they hadn't been on ECMO. So what this was actually like a maternity patient. They had a thing called placenta prurita. So essentially that's where the placenta penetrates through the uterine wall and basically causes severe bleed, like massive hemorrhaging, was going into refractory cardiac arrest. So at the facility that they had been at, they received about 100 blood products over there. They were massively bleeding. They had ended up responding to putting them on ECMO because of that. They kept going into cardiac arrest. They were extremely overloaded from all those products, but you had no choice because you were giving, they were just hemorrhaging completely. So they responded, cannulated, and then ended up coming back, transporting over to All Saints. And whenever they got there, I guess their abdomen was super distended. They had to take them to do like a laparotomy and relieve that pressure, and essentially went through a course of going through multiple cannulations and received 234 blood products over 7 days, all in all. Plus, if you're not counting the cell saver and other product stuff, it's probably close to 300 throughout their stay. Ended up getting decannulated after day 7 and is neurologically attacked, and her baby as well too. Literally would have died if it wasn't for ECMO. And it's a very unique case. They literally depleted the blood bank in Fort Worth, but since it was right there, they were able to get another shipment. So it definitely took a ton of resources, a ton of well-educated staff, but she survived and is doing well to this day because of ECMO. So it's a really unique situation with that. And then on y'all's PowerPoint, you can actually read the whole abstract there. It's pretty well written to see like sort of the chain of events and stuff like that. So going towards what we did at All Saints, when we implemented the ECPO program, we actually started, at first we didn't have any like providers to like first assist with the cannulation, so us charge nurses actually got trained to do first assist with an ECMO cannulation. So that's me. We were sort of running through the hands-on simulation stuff of it. Well, we hit a whole ton of roadblocks throughout that process, tons of anxiety, low morale, all the good things. And we ended up, that's what gave me the idea to do like video training with it. So I implemented a whole entire video training program that was like ECMO cannulations, which we'll go through on the next slide, circuit builds, like all the different things related to ECMO. And then you're having actual experience. So using those two, hands-on and video, and then actually doing it was like the trifecta of like, you feel really comfortable doing this. So that's sort of what I'm going towards doing with education at UT Southwestern now. But I was doing this is all this year pretty much of like implementing this. So we'll go through what an actual VA ECMO cannulation. But essentially this is what one of the videos, it was like maybe like 60 something videos we created. But this is like prepping them for an ECMO cannulation. You're using like a betadine CHG stick there to prep. Then you're getting sterile. So that was a process of what we had to learn, was learning how to get sterile. It was another anxiety thing that we had to overcome. So this is sort of the process of getting sterile. So you're sterile if you're first assisting, and then the surgeon who is cannulating is getting sterile. So that was that. That was our CT surgeon, who all participated in this, which was really cool. So then now you're handing over the sterile femoral drape to prep them after you had prepped with the wand. So that's done in a sterile manner. The stickers were an issue we had, so that's what we focused on with that. And just the placement to get the drape, because you're doing this with all the adrenaline going on. Your brain is not working as well compared to like a still learning environment. So this was what we focused on with getting the drape on accordingly, and we would drape and prep before the CT surgeon arrived, and that way we didn't have to do those steps. And it was, when they arrived, we were able to go straight into the cannulation aspects. So they have little stickers, so they stick to the legs of the patient, since we're doing femoral access there. And then we're handing over all the equipment that's needed for the cannulation in a sterile manner. And basically each of those kits is, each one is for accessing either the artery or the vein. And so you'll go through like dilators, a scalpel, the wires to go in, and you'll see that whole process here in a second. And then you'll make the ultrasound sterile, so they'll open that up and you'll put the ultrasound in, and then you'll pull it as the assistant person. So that's able to sterilize the ultrasound for the provider to use for getting access. So that's like our pump pan, essentially, what we called it. It had like clamps, Mayo scissors, and tubing or needle drivers for the sutures. That was another learning point that none of us knew exactly when we started ECPR, and just understanding what those are, and whenever they ask for that specific thing, to know what to grab for it. And then just another visual shows the dilator sizes and stuff. The pump pan is for putting saline on, which you'll see when we do wet-to-wet connections for the circuit and the cannulas. That's what we end up using for that. And the ECMO specialist a lot of times is the one that's doing the role of like putting sterile stuff on the field, putting gauze if it starts bleeding so they can visualize the cannulation, and then just really making sure they understand the difference between the two like kits, because one has a longer wire for the venous access. The cannula goes way up towards the right atrium from the right like femoral vein, so it's a lot longer. So that's why it's important to understand the difference between the two kits. And then we do a thing called a reperfusion catheter. Since the arterial cannula goes into the artery, it will block the blood flow going down to the limb a lot of times due to the size of it. So we put the superficial femoral cannula, or what we call distal reperfusion cannula, to provide blood flow going back down to the leg. So that's what they're doing here, is getting the wire in for that cannula specifically. So that way, whenever they have the cannulas in, they already have the wire to be able to put it in. So this is the arterial access first. And then we'll remove it, so you have your arterial wire there. And then now they're gonna get their venous access into the femoral vein. And that's what this process is. That's the wire. So the assistant is basically going fluid and making sure you don't break sterility by like making clot all over the place. And then they'll give heparin typically after we get all these wires in, because once you put those cannulas, your body's gonna try to create clots, and which is not good. So you'll give the scalpel. They make like a little cut down incision to sort of help when we put the dilators through those wires. And then we'll go from the smallest to the largest of the different kits. So here the surgeon is gonna be manipulating and slowly increasing the size of the vessel that they got the wire into. And that's why you go steadily larger in size in order to get to the size of the cannula. So like the arterials are like 18, 17 French. So you're getting up to that like 18 French size gradually with the dilators. The largest one is the 16 French, so it's like right under the size of that arterial cannula that you'll be placing. And then the venous ones are a little bit larger, which we'll go into after we get the cannula in here. So here, that's the arterial cannula. Is a lot smaller, but it shoots blood up pretty powerfully up to the heart there from the femoral artery. So that's where they're getting. This is important because if they don't insert it in the right way, it can cause damage to the artery. Maintaining a steady while they insert it, and then whenever they're ready in the place, they'll take all the stuff out, and then the surgeon clamps, and you should get quite a bit of blood flow back. Now they'll go into the venous side of things, and that's where the gauze comes in handy. It's just sort of clearing out the field on that, and then they're going to dilate in succession for to get up. I think the highest one on this one is 18 French. The venous cannulas are like 23 and 25 French, so they're quite a bit larger in diameter than the arterial cannulas. So sometimes they would the surgeon would like to dilate after these with like an actual what we call an obturator of the cannula, which is what sort of helps it go into the vessel. And that will be like almost the size of the cannula, so sometimes I would use that as well, just to make sure it's big enough to get that cannula in. But this is the largest dilator, the 18 French. And then now this will be the large, long venous cannula that we were talking about. It came separated, so we would have, that's the first assist, we would have to connect those together. And you can see this is also some education, trying to make sure we didn't make it go up in the air and break sterility with that. And that's the obturator that she was attaching into the cannula there, that I was sort of talking about. But it's very long. That goes all the way up from the femoral vein, all the way up to like the right atrium, almost, to drain out the blood for ECMO. So those little, very long So we are focusing heavily on making sure we maintain sterility with that. And then while they're doing that, the ECMO specialist is down there on the bottom left. And he started getting the circuit, that's the sterile part that we're gonna hand over. And that will be the tubing we connect to these cannulas here. So same here, they remove all the stuff off the cannula while the surgeon's ready with the clamp, because the blood's gonna come fairly quickly. That, and then the clamp. So if you're not on top of it, you could easily lose a ton of blood. A lot of times we'll give a blood product anyway after it. But you'll hand over the sterile stuff. That's what they're grabbing there. And then they sort of drag it out. So as you can see, there's a reservoir bag there, and that tubing there, that's what they're gonna cut and disconnect from that. That's how they prime it and all that stuff. But they'll clamp and cut, and those parts will be the parts that connect to the actual cannulas. This is just some ECMO specialist education regarding what they need to keep the flows at. So the clamp, cut those, and then sort of bring them over to the cannulas here. And then this is where we go to wet connections, like we were talking about with the saline. So the assistant will continuously pour the saline, and then we're basically getting the air out of the connections while the surgeon connects it there. And then they can unclamp. And then for the arterial, same thing. They may let it back bleed a little bit to get some of the extra air out, and then same process, connecting and getting the air out, and then unclamping. And that top part is what that distal reperfusion catheter connects to on the cannula. So now we're about to go on ECMO. So this is where they'll be flowing, and then most of the time if they have a blood pressure at like 50/30, this is when they become like their MAP or mean arterial pressure gets up to like in the 60s, 70s, and they're finally getting stable. It's pretty crazy to see in real life, like it's like that almost. Especially if you're able to flow on ECMO, then it does wonders. And then now once they're on ECMO, if it's like a more of a scheduled cannulation, we'll sort of dilate and put the reperfusion catheter on in what we call the superficial femoral artery, right next to that femoral artery that they had gone into for the arterial cannulation. So this is just dilating. It's a series of steps of slowly like getting a longer wire, and then they're going to dilate with the actual catheter that they use. This was also a learning point that we had a lot of trouble with that since we didn't do a whole lot. So we made sure to emphasize like every single step when it came to getting this catheter in, because this is very important for maintaining that lower leg perfusion. Because people have lost legs if they didn't have like one of these catheters in and it occluded enough blood flow down. So this is sort of the last point. This is like the catheter. And then they just prime it out using the blood. And then they attach a little connector piece to it, and then that's what's able to connect to the cannula there. And which we actually have to go off ECMO whenever we attach it, because if you were on still, they open that cap and air gets introduced into the cannula. So that's why they clamp here, and it's sort of like communication between the ECMO specialist and the surgeon. They clamp real quick, we're off, because they clamp up on the circuit, and then they attach, and then unclamp, and we'll go back on ECMO at that point. So now you have your whole set of your arterial, venous, and your distal reperfusion catheter. And then at this point, they'll just suture the cannulas, dress it, and then if it's an ECPR situation, a lot of times they're going to take them to CT, try to figure out why they're coding. They'll do like a CT of the chest if there's like a PE or something, and And then if that's the case, then they may try to take them to like cath lab or IR or something to address that specific cause of why they're coding. But that's essentially, ECMO gives them the time to do that. If they didn't, they would die, essentially. Those ACLs can only go so far. So with that, the only difference is they're not gonna worry about the reperfusion wire until after they're on ECMO and supported, then they'll place that. But yeah, that's essentially what the video entailed. And then those are just my references. And then I can take any questions that you'll have about CVICU or ECMO.